Hey, David.
Hey, Laura.
Guess what I did last week?
What'd you do?
I was invited to a birthday party
Okay.
of a little baby that was born at 25 weeks in a Target restroom stall.
What?
Yes, was resuscitated successfully, was stabilized and brought to Glennon and cared for at Glennon, and is now doing amazing, happy and healthy at 1 year of age.
Okay, so 25 weeks, that's early. Like how big was this baby? Like 1-2 pounds, something like that?
Yeah, like a little over a pound.
Oh my gosh.
When he was born. And I mean, I'm an old nurse, and I definitely was not a NICU nurse. I can't do the tiny humans. I can't do that. But when I started as a nurse in 1990, I don't believe we had outcomes like that. I mean, I was reading an article lately that said something to the effect that a 2-pound baby that was born in and around like 1960s era would have like a 95% mortality rate.
Oh my gosh.
But that same baby approaching the year 2000 would have like a 95% survival rate.
I mean, what a huge shift, even just in like 40 years. Like, it's really amazing to see how healthcare and the medical field has been evolving for good over the past several decades.
For sure. So much change, so much good change. And U.S. News and World Report has named Cardinal Glennon's NICU as one of the best neonatology programs in the country. Yeah, we are. Right. So we should probably talk to some of the people doing the work, right?
We should. Yeah, we got to get some people on here. So who we got?
So our guests have literally been practicing long enough in critical care settings and taking care of the sickest babies for over 40 years. Each of them has been practicing over 40 years. So they really have been part of the journey of seeing those odds flip, you know, and change almost since neonatology was a specialty. And we're going to take a brief but illuminating look back in history and kind of see how things have evolved in the care of sick babies, and then kind of talk a little bit about where we're going and where the future's heading in that field.
So one of our guests, Dr. Robert Fleming, who has over 40 years of experience in the field of neonatology at Cardinal Glennon. So he's going to be here to kind of talk through some of that history with us and what he's involved in.
And we're going to have Dr. Lottchen Wider, who just retired last year from Cardinal Glennon after practicing for 40 years, but she still comes back to Glennon and volunteers every week in the NICU.
Wait, she comes back to the NICU after practicing for 40 years
as
a volunteer?
She sure does. Dr. Wider has been so involved in nursing and research and education for 40 years. She's still a Professor Emeritus at Maryville University. She still teaches. She can't get enough. It was too much to do a cold leave, so she comes back every week and spends time with the babies.
What an awesome pair of people. I can't wait to get them in here and hear about their background and learn more about neonatology.
Let's do it. Well, welcome, Dr. Fleming and Dr. Wider. We are so excited to have you.
Well, we're happy to be here.
Yes, we are. You are sincerely two of the OGs, the originals of Cardinal Glennon's neonatal intensive care unit. So I must ask you, so for our lay audience, when we say neonatal, I mean, y'all know what that is, but sometimes people don't really know what that means. Are we talking about all preemies? When we say neonate, what does that mean?
Well, you know, like many things in medicine, we take a familiar term and we make it Latin, and then we sound so much wiser. So neo means, of course, new, and nate means birth. So it's just a medical term for newborn.
Okay.
Yeah.
Okay. So we're talking about newborns. So they're not all preemies that are in our NICU.
No, certainly not. The majority are, but there are a number of babies that have reasons to be in a newborn intensive care unit that are not preterm. They may have infection. They may have congenital anomaly. They may have a surgical problem. They may need some nutritional support for a period of time. And they constitute a significant fraction of the babies, especially here at Cardinal Glennon.
Well, and Dr. Fleming, I've read that about a third of the beds at Cardinal Glennon, we say we have 195 beds, and a third of those are NICU beds. So do we have like a high rate of neonates that need to come to Cardinal Glennon for care?
Well, yes, there is a substantial need for newborn intensive care units, and not just in the St. Louis area, but nationwide. And you'd be surprised at the number of babies that need some extra help to get off to a good start after they're born. And this need has not actually decreased over time, and the number of overall newborn ICU admissions has actually increased over time. So it really is meeting a need that is substantial in the community.
So, Dr. Fleming, you have been in and around this specialty of neonatology kind of since the beginning. I mean, pediatrics became a specialty, right, after World War II and, all that. But then neonatology is a specialty within pediatrics. So you graduated medical school in 1984, if I'm right, from SLU. So you've kind of been around since the beginnings of when this became a specialty. What inspired you to become a neonatologist and take care of the babies?
All right. Well, that's a good question. Despite my appearance, I wasn't really there at the very beginning of all of this.
I didn't mean to infer you're old or anything.
I did my pediatric training at Vanderbilt, and Vanderbilt had a large and very active, very vigorous NICU setting. Dr. Stallman there was really one of the founders of neonatology, and then one of my mentors while I was there, while in the NICU. And
so they were around at the beginning.
Yes. And she pioneered a lot of newborn care, was really quite instrumental in a number of advancements, especially in respiratory care. And we had a rather large referral area that we brought babies in from. And these babies were largely those with respiratory distress then. And that setting, to me, was a fascinating one, partly because of the emerging technologies that were taking place in the field, a very vibrant field as well, with ongoing advances in technologies, but advances in understanding the underlying conditions that needed to be managed. I also was taken by, in those days, the NICUs were open wards, and so everything was all happening out in the open here. And just to see all of these people so dedicated to doing right by the babies, to see all the different families and their interactions, which at that time needed to be relatively brief. We kind of kept the parents, at a bit of a distance because, there were concerns, clearly unfounded by our current understanding that, it's best to leave the babies alone, kind of a thing. But to see all of them from various backgrounds, it could be a business executive, or it could be somebody from out in the country, or somebody who's got no resources from the city, and there they all work together with this common issue of a sick child, and just seeing all of that dynamic was really impressive, and I really took to it, and have enjoyed the ride, so to speak, as the care has advanced, as we're doing so much better by these babies over the years. It's been a great thing to be a part of all that.
Well, not just, I think, care of the baby, it's also care of the family.
Absolutely.
Yeah. Because that baby will go home with a mother and father and siblings and all of us who care for those wee ones. It's a parent's greatest fear is to have a child in an intensive care unit. And it's really quite remarkable. And I think it's a team, too, that
Absolutely, yeah.
get those babies back home safe and sound where they belong.
So, Dr. Fleming, you indicated, and you're so right, that there's been massive advances in the field of neonatology over the decades, right? Profoundly different and more sophisticated technology, changes in how you feed babies, changes in the NICU environment, so many things. If I asked you to focus on technology and medical advancements that have moved the needle in your field, in other words, made things profoundly different now than they were, say, 20 years ago with regards to outcomes and things like that, what are those top things that you think have really moved the needle in the field?
Yeah, so when babies are born early, the lungs are at a stage where everything is done by the placenta instead, in terms of providing oxygen,
Sure,
getting rid of carbon dioxide, as well as nutrients and that kind of thing. But the lungs don't do a lot during fetal development other than grow. And they grow in an environment that is very different from the world outside. And if they're born early, the lungs aren't yet prepared for that in a number of ways. But one of the most important is that they don't make a particular substance that coats the surface, the surfactant, the surface of the air sacs in the lungs. There's no reason to make that because you only need it because you have air and fluid back to back, right next to each other. And if you don't have air and fluid, there's no reason to have this substance. And, it only makes sense for Mother Nature to make it so that you start making that right at the very end.
right.
And if you're born early, the absence of that substance tends to make the lungs want to collapse down, and it makes them difficult to move air. And thus, when I was a resident and we didn't have surfactant, we had a lot of babies where you really had to be on top of all their ventilatory settings. And even with that, the lungs would pop, trying to get those very stiff lungs to open up. And we had to put tubes in their chest and that kind of thing. The incidence of pneumothorax or pop lungs is really dropped off quite a bit, and mortality has gone down, and the ability of more and more preterm babies to survive has gone down as well as a result of surfactant. This is a treatment that actually goes to the mother, but it's for the baby, is prenatal steroids. So if moms are at risk of delivering a baby early, and the mothers receive steroids, those steroids will then get into the fetus, and it will help actually push the lungs along a bit in their development and make them more ready for air breathing and rev up their surfactant system. And that has really changed the nature of our biggest challenge, which is ventilating these babies, and made it such that some very preterm babies, even though they might be 26 weeks gestation, if mom got steroids, their lungs behave a bit more mature than that. And that has made a major difference. It's not like a major technology, but that has made a major difference and allowed much smaller babies to survive and to do better. So I have to include that one. And in terms of technology, I mentioned the ventilators and needing to watch them very carefully and that kind of thing. And now they're so sophisticated by comparison. In those days, we would just look at their chest to see how much it was rising and falling. If we're giving too much push on the ventilator, is it the right amount? Now there are flow sensors that can sense exactly what the size of the breath is, and I get a constant readout on how big or how small the breath is. Wow. We can set the ventilators to give a particular volume of air rather than just push with pressure. That has made a difference. There's a novel mode of ventilation called high-frequency ventilation, and these are ventilators that go at extremely rapid rates, but very tiny breaths.
So short, like quick little breaths.
Yes.
Wow.
Yes. It sounds exactly like that in the room.
She's been around a few.
Only quite a bit louder. And
Dr. Wider, we'll have you do auditory effects. For
yeah,
the
right.
podcast.
You'll be in charge of all sound effects. And well, if you're at the bedside long enough with a baby on the oscillatory ventilator, that sound is just going to resonate with you for the rest of the day.
Hear that in your sleep. Mm-hmm.
A fascinating concept. It all came from the fact that we don't actually need to move air all the way from our mouths all the way down into the lungs to have the exchange of gases. And that observation came actually from noticing how dogs can ventilate themselves with tiny little panting breaths that aren't as big as a full breath all the way back and out again. And it's like, or in medical terms, they could breathe with tidal volumes less than dead space in their lungs. Okay, so
can you imagine the conversation at that table?
Well, yeah.
Somebody's talking about their dog and panting, and somebody says, "Wait a minute."
Well, they do it.
Who knows?
But
Yes.
Dr. Wider, I'm going to flip it to you. We kind of inferred earlier on in conversation that the environment has so changed. It kind of one of the things you said, Dr. Fleming, that inspired you into this field was being able to see all of these happenings and all of these people in a common environment taking care of the babies, right? So, I remember when I started at Glennon, we had a semi-private NICU and special care nursery, and everybody was in 3 big rooms. The environment has changed substantially in the neonatal care, and they found that the environment matters. So talk to me about the evolution of the environment and all the things that are different now, not just for staff, but for families, and talk about the evolution of where we were and where we're at now as far as environment goes.
Well, much like Rob, when I started, we had an open ICU at Cincinnati Children's, but at Cardinal Glennon, the original ICU was maybe 3 or 4 beds, and that was it. And then all the sick children were what we called specialed out on the floor. And there were ventilators all over the hospital, and that rapidly evolved into specialized units, intensive care units. Interestingly enough, Florence Nightingale was the first person who came up with the notion of put your sicker patients closer to the nurses during the Crimean War. Wow. So she's credited with coming up with the notion of ICUs.
Flo was smart. She was.
Absolutely.
She was a statistician.
Mm-hmm.
At any rate, today the environments are calm. They were very chaotic in the early days, the ICUs, because it was all open and it was very noisy, and there was very little privacy. Boy, and can you imagine losing a child with
an open
others
ward.
In an open ward, yeah. And that happened frequently. I think seeing that as a young professional, young physicians, young nurses, witnessing that, I think it made everybody go home and say, thank you, God, don't ever let me know that kind of sorrow. But thank you for the opportunity to help people who are struggling.
So what made the shift? Was it best practice? Like, I'm assuming there's reasons we evolve from that kind of common area to an all private room space. So what are the advantages of that? And then we can speak to the change and what it was like for staff to go from that kind of learning culture, right, to the all private. So I'm assuming there's a best practice in there somewhere. Yes.
Well, I think in the early days, everybody knew it wasn't best practice to lose a child out in the open. The infection rates, you just knew to have an open ward that was not optimal.
Yeah, so I think there was an increasing recognition of the importance of the parents as well, and to try to encourage their bedside presence as much as possible, and to give them at least an area that is theirs. We didn't appreciate the real importance of the parental involvement, not only during the actual care of the babies. One of the advances in the field has been encouraging skin-to-skin care, where the babies are actually kept warm by the mother or the father's direct skin-to-skin contact with the babies. And there are objective studies showing improvements and important outcomes as a result of that. This whole process of parent-infant bonding, it's a real thing. It really is, and that attachment, I think, is beyond understanding, and so very important. And we were disrupting that at that time.
I would say what a win for the parents, too,
Yes.
because I meet so many parents of NICU babies who feel like they got cheated, and they're grieving that normal, bring the baby home, all the bonding, all the firsts, they grieve that. And there's some, maybe the word's not bitterness, but bitterness there, and a loss of control. And so, this kind of doesn't give it back to them. Nothing can replace that quote normal start, right? But to afford them whatever opportunities there are for participation and bonding. And
Well, it's so frightening. And, a father has been through childbirth with the mother as well, but the mother is still in the birthing hospital, and the father and a baby. And from the get-go, I think the team always makes an effort to include that daddy, because he's just been through childbirth himself with the mother. And, I think we do a nice job of trying to address the sense of powerlessness when they hit our door.
Yeah, and I'm glad you mentioned the fathers in particular, and that's an aspect of NICU care that has, I think, been given too little attention historically. Typically, we tend to direct our discussions to the mother, sometimes as though the father wasn't even there, or maybe, occasionally an acknowledgement or something like that. And I still find myself, directing a large part of my conversations to the mother, and then, catching myself and saying, talking to the fathers as well. Both mothers and fathers go through the kind of grieving process that you're talking about, and it affects each of them very often somewhat different.
it's so crazy that you're saying this right now. Do you want to know why? Because there's a family. I'm not going to mention them right now, but you were one of their key neonatologists, and the mom and the dad were having a discussion with me about how differently they dealt with their NICU experience. And the mother was saying how she needed the touchy-feelies and the celebrations of the little milestones and the things like that. And the dad was saying he needed all the knowledge, like he needed all the explanations and the medical explanations. And she was like, yeah, that's all you. I just need this, and this, because she was doing all that replay and all that stuff. Yeah. And the dad was like, no. Like, I want to hear all the information. And hearing you explain the surfactant, I literally was sitting here going, he's so good at that. Like he explained that really well. And that's exactly what that dad said. He goes, I really appreciated Dr. Fleming because of all the people that cared for us. He brought it to my level where I could really understand it. And that was everything to me. So
One of my
there you
dear
go.
friends
Thank you.
is a qualitative researcher, and she studied the experience of daddies, NICU, of NICU babies. And one of her papers was the primacy of work. The fathers felt, like you said, Rob, that they needed to be the protector, and the only way they could protect the family was to continue to work and let her deal with what's going on in that NICU.
Interesting.
Yeah.
And, in reality, we'd really like to pull them in and, have them fulfill that very important aspect of parenting.
Back to that team aspect that you both have alluded to, not just with the team of experts in the hospital, but the team of the parents for the child.
Yes. Yeah.
Mm-hmm.
I want to touch upon something. So it's been a question that we've had when people come into Cardinal Glennon for the first time that ask this, and it's kind of a common misconception, but not all of the neonates that come into our NICU are emergent. I mean, can you speak to, we have the amazing resource in Cardinal Glennon for the Fetal Care Institute. And so there are some families who come to us that may have gotten a scan and get some information that are a little more prepared for their journey ahead of them. Can you speak to kind of that roadmap for some of our families that come to the NICU?
Yeah, so prenatal diagnostics is another area that has really advanced quite a bit. When we first started, it was not routine at all to get an ultrasound. It was only done in certain specific situations. But now the ability to identify babies that are likely to need surgical intervention or maybe subspecialist care can be identified before birth, sometimes even managed before birth. And we can get the families prepared for what are the likely steps after the baby's born. And very often, if it's a situation where they're going to need an operation, but it's not right now, or they're going to need subspecialty expertise, we can keep the mom and baby together at St. Mary's and then transport the baby at an appropriate time. On the other hand, if they're rather complicated or born early or going to need subspecialty expertise early on, then, or at any point they seem to need it, then they'll be transported over to Glennon. So, we do try to attend to meeting the parents' needs to be with the child, especially the mother after birth. It's a difficult thing to have the baby whisked away. Very often we have to do that, and so the Fetal Care Institute is something that's developed over time in many referral centers that take care of critically ill newborns, and sometimes it actually involves fetal care, fetal surgery even, but prenatal counseling with the family. We have the subspecialists come by and talk about what to expect from their end of management. And I think we make it a less frightening experience for the families, and give them some sort of a sense of what to expect and who we are. And, the baby's not just disappearing to who knows where with who knows whom. Yeah.
I can't even imagine how that service and that philosophy, I guess, of care has really impacted outcomes and mortality of babies and things like that. Just knowing all that information up front and being able to intervene medically sooner or in a planned sense versus the chaos of delivery and finding out something and having to act on that. And yes, parental preparation, you can't take the situation away, but you can certainly be a bit more prepared and get to know your family a little sooner and develop that trust and things like that
our
earlier.
Katie Francis, who manages Glennon's Fetal Care Institute, started the Fetal Care Network, a national network.
Yes, she did.
So there are, fetal care nurses around the country then who network and now have their own professional organization because of our Katie.
Yeah.
My goodness.
Yeah.
And it's not just a matter of preparing the family, it's to prepare us for what we might need to do in the delivery room. And there are some babies that are going to need immediate management. There are some for whom we'll need to have, if they have airway issues, maybe we'll have to have the otolaryngologist actually there in the delivery room. If they have certain heart problems, we'd want to have a cardiologist there with us in the delivery room. It allows us to be at the ready for a problem that we know about. We always are at the ready for the unexpected, but if we can have, everything in place, that just makes everything go all the better.
You just can't put a price tag on that. I mean, I think about 3D printing and how some of our specialty surgeons like to have that model so they can practice with their instruments, before they actually have to open up a patient. There's been so many of these advances that, as you both are well aware, survival of many of these younger and preterm and very sick infants, is slowly turning from the exception to the standard. We're surviving more and more of these babies. Is there a particular story or case study for each of you that you can go, okay, this would never have had this good of an outcome 20 years ago? Like, is there something that just resonates? And I'm sure you've been here a long time. There's a whole lot of stories, I'm sure. But is there one that each of you can think about that it's just like, wow, we did good. We couldn't have done that. That child wouldn't have survived 20 years ago, Dr. Wider, you go. You look like you're ready.
There are just so many on a daily basis.
A baby that comes to mind was one who actually spent an entire year in our NICU. And
a whole year?
Yes.
Oh,
yes,
my goodness.
Yeah. It doesn't happen often, but it does happen. I sort of keep track of, I've got a sort of a list of babies that have spent 365 days plus in our NICU, and this little boy was one of them. He was born not only early, but the mother's water had broken early as well. And I mentioned how important the lung development is in the womb, and there's something about the back pressure from that fluid that helps the lungs to grow and develop. And if you don't have that, they sort of arrest in their development. So not just premature lungs, but what we call hypoplastic, which is, again, just some foreign language adaptation to make us sound smarter of, undergrown is what it really means.
We like your big words.
I'm fascinated by the Latin tie-ins.
Yeah. So hypoplastic as well. And that can be a very difficult combination. And that infant was on a lot of respiratory support, including that high-frequency ventilator. The neonatologist who was caring for him initially, Dr. Sadiq, who was our clinical director for many years, was using a rather unique ventilatory strategy, even for that being a somewhat special ventilator, and was able to get that baby through that initial phase. But he went on to get what we call chronic lung disease of prematurity, or bronchopulmonary dysplasia, which is too much to say, so we say BPD, and was ventilator dependent for a very long time. There were, people very concerned that there's no way he was going to make it, and that we're just eking him by on a day-to-day basis, and is this right to do? And because the last thing we want to do is have a baby spend a lot of time in our NICU and not go home. Our goal is to get babies home from the NICU with their families, to live a life with their families. And so, a lot of concern about that. Over time, with some thoughtful management and with the parents being absolute, believers that he was going to make it through. Sure enough, he did. He was on, not ventilator support, but too much support to actually go home for a period of time. And it was part of the reason why he was in our NICU with a little mailbox of his own and a welcome mat. But he looked so cute in his birthday, and this is a family who who came from a very resource challenged background, and I'm sure that this child's hospital bill was astronomical, and yet we are able to do right by this baby, and to give that baby as good a care as could happen anywhere. And I think that's speaks volumes about who we really are as a society and what we really want to do for those that are underprivileged. We want their children to get off to as good a start as humanly possible, like every child. And he went home not long after that. And little boy running around, he's a bit hyper apparently, but
he's making up for lost time.
Yeah, that's right. Yeah. And they've been meeting some developmental resources as well, having been born that early, but far exceeding what anybody might have imagined. And there's no way that infant would have survived, beyond days. And when I first started, it would have just been inconceivable that maybe even to make it a day. Quite a difference. And an amazing thing to witness. Yeah.
When you were talking about that baby who was there for a year, and there's those times where you as clinicians are circling and going, what are we doing?
Yeah.
Like, are we helping truly? Are we
serving
hindering
this baby?
Are we serving this baby?
Yeah.
And I can't imagine the conversations that actually do happen, that have to occur, and that you're having with parents, but then the own individual when you go home at night by yourself conversations.
Sure. Oh yeah. Absolutely.
What are we doing?
Yeah.
Am I doing the right thing?
Yes. Yes. Oh no. I wondered that a lot. I think there's so many uncertainties, and one of my aphorisms that most people don't like hearing is that what's the plan? I'll say the plan is to be flexible.
Yes.
Put that on a coffee mug.
Yes. So true.
Yeah. So it's like we know what our immediate plan is, and intermediate, it's a little fuzzier. We do have to, think ahead over the whole picture. But there's a lot of uncertainty, and when we get too adamant, I think we're going to disserve that reality of the uncertainty. I have to say I admire all of the parents that I've worked with. Are some better than others in different aspects and ways, yes.
And they evolve too. Their plan is to be flexible, right?
Yes.
I mean, sometimes all they want to hear is something hopeful.
Yes.
And they're not ready to hear reality.
Yeah.
And you got to ebb and flow with where they're at and what they're ready and willing to hear and converse about too.
I don't know if the public knows what a special place Glennon is. Rob and I grew up together professionally at Glennon, and your career oftentimes defines a big part of how you view yourself, and to be able to have grown with people who were on the same path as you, who had a real drive to make a difference in families' lives. Glennon is this place that just doesn't care for the children. I mean, we care for the whole kit and caboodle. And as both of us have said, we do so from a perspective of a professional, but also from perspectives of parents. And again, you just treat others the way you would want to be treated, which is what Glennon has always done. And I came back, I missed it. I left for 6 months and thought, oh my God, you cannot do this cold turkey. So I went back, and I still teach then at the university, and I missed the babies. You know, if you're good with babies, if you're a baby person, you need to be with babies.
So speaking of retirement and things like that, Dr. Wider, we're friends of friends on social media, I think. And when you retired on your last day at Glennon, you made a post on social media and you stated, Cardinal Glennon has been ever so much more to me than a workplace. You see, I professionally grew up at Cardinal Glennon, where I learned from mentors that intellect, competence, compassion, kindness, eloquence, and hard work transform our patients' lives in ways that positively influence their futures. Nurses are a privileged lot. We see life at its best, at its worst, at its most vulnerable, and its most holy, another lesson for which I am grateful. You both honestly do work that I could never do. I could not handle those babies. They scare me to death. And I would just love to offer a small little blessing over the two of you, if that is okay.
That would be wonderful.
Okay. All right, Father. Thank you for the gift of these two amazing humans, these special caregivers and teachers who have inspired many an NICU colleague and who work with our tiniest little patients. Babies can't tell us their needs, so they have to use every one of their senses in caring for these babies. Help them as they navigate the delicate balance between hope and fear that envelops the families of these tiny miracles. Give them the wisdom to provide expert care, grace to teach the parents with patience, gentleness to support their souls, curiosity to ask how we can do it better, and resilience to learn more and share beyond ourselves. Thank you for allowing such treasures like Dr. Fleming and Dr. Wider to have been part of our Glennon family. Help us to follow their example and humbly serve with passion and devotion.
Amen.
Amen.
We hope you enjoyed this episode of The Glennon Factor. Make sure you follow The Glennon Factor and leave us a review wherever you get your podcasts. Visit glennon.org if you would like to learn more about how you can support Cardinal Glennon kids. And while you're there, feel free to share any feedback or episode suggestions on our podcast page. The Glennon Factor is recorded and produced by SSM Health Cardinal Glennon Children's Foundation.